towards new concepts, to new drugs, to new therapies. And slowly the world is moving towards, as even surgically, if you see, we are moving towards more and more minimally invasive procedures, more patient friendly, from femoral to radials, like what we are doing. The catheter size is going down from 8 French to 6 French, even 5 French. The hardware becoming more and more friendly, same-day discharges, 4-hour hospital stays. So the whole concept is now changing from not only giving a very good healthcare to the patients, but also a convenient healthcare that the patients can get and can afford. I really applaud the Cadila Pharmaceuticals for coming out with this conclave on innovations, because that is the need of the hour. And I mean, pharmaceutical industry apart, even hospitals need to innovate, and in ways so that more and more people can actually take the benefit of therapy, the benefit of treatment, and get themselves rid of the diseases that we have. The second point I just wanted to make was that as a cardiologist, I've seen the whole spectrum of patients. We used to learn in our MDs that 50-year-old males and 50-year-old females were the first risk factor for a heart problem. But nowadays that's not the case. We are treating 25-year-olds also, and they don't seem to have all those risk factors that we study in our textbooks or which we are still studying. The point is that there is something beyond all these things that is happening, especially in the Indian subset, and we need to look into it very, very minutely. The reason, we are a very young nation. If you look at the overall workforce, nearly 40% of the workforce is young population. And if this young population is going to be afflicted by diseases, afflicted by heart problems, afflicted by MIs and ischemias, and God forbid 10 years down the line, 15 years down the line, this will be a crippled nation. If you look at it in a demographic way, it is actually an epidemic that we need to arrest at this point of time. And probably the concept of polypill is just one way of try and arrest the whole the gamut of epidemic that is going on, probably. So the talk today on innovation, lifestyle diseases, I will be just touching upon this concept of polypill and the Polycap that we have studied during the course of this concept. As Archimedes very aptly put it, give me a fulcrum and I shall move the world. It is need a concept. You give me a concept, you give me an idea, and I can work it out, right? So this concept was triggered first by Salim Yusuf. It's somewhere in 2002. In a paper in Lancet, he mentioned that, see, if you look at all the drugs, you look at aspirin, you look at beta blockers, you look at ACE inhibitors, you look at aspirin, statin. These drugs, they are known to cause a reduction in cardiovascular problems, in cerebrovascular diseases, in incidence of strokes and MIs, correct? So why not combine them in a fashion so that if given to a population which is at high risk, whether primary prevention or secondary prevention, we could maybe get a reduction in overall incidence of heart problems. So that was a hypothesis which was propagated by Salim Yusuf way back in 2002. Come 2003, and a similar concept, of course, Yusuf talked about only 4 molecules, but Law and Ward in their seminal paper in BMJ, they came to the concept of 6 drugs. They added thiazides, they added folic acid to the formulation on the belief, because at that time homocysteine was supposed to be one of the important markers for premature sclerosis. So they added folic acid to the concept, and they said, the data meta-analysis of all the drugs said that if you give these 6 molecules, thiazide, beta blockers, ACE inhibitor, statin, aspirin, folic acid, 6 molecules to a high-risk population, the incidence of heart problems, of cardiovascular diseases would go down by the tune of 84 to 85%. Strokes would go down similarly by 86 to 87%. Huge number. By simply giving them a molecule. And they commented in the conclusion that this is probably the single most innovative intervention that we can ever do for mankind. Because if it is going to cut the incidence by 85%, you can imagine out of 100 people, only 15 are actually going to have a problem. High risk patients, not about the population in general. Of course, they went one step ahead and they said that if you sit down and look at all the risk factors, it's very difficult. So we need to assume that 55 plus, most of us are going to have hypertension or diabetes or dyslipidemia. So they gave the concept that why not to give the polypill to all people beyond 55 years, and as something like a vaccination. If we give it across board, probably you will get the results much better. So it was a hypothesis that was propagated by them, and I think that is how the whole journey of Polycap started. They came out with a formulation that was propagated by law and ward. Of course, folic acid was not put in because we found out, that although homocysteine is an important risk factor for atherosclerosis, correction of homocysteine does not cause a reduction in needles. We have enough data on that, right? So the concept of folic acid went out, and so they came out with this combination that probably this is how it's going to work. So that the journey began. They did tips 1 in primary prevention, tips 2 in secondary prevention, and they showed that the results are good. It is safe, efficacious. Patients do not have any issues because there are a lot of problems. You give beta blocker, you give inhibitor, you give thiazide. The first thing that comes to your mind, what the patient lands with hypertension, correct? You give aspirin across board. The first thing that comes to your mind, if you give aspirin to everybody, what about GI bleeds? What about ICH? What about other bleeds? You give statins across board. What about myopathies? So these are certain issues that probably tips 1 and tips 2 try to answer. That is, it is safe. You can give it across board without any problem. The effects that would come out as per the hypothesis would be very good, and that's how the whole journey started. So, as Dr. Gagusha put it, innovation, yes, it improves quality of life, it saves millions of lives. It of course reinvents practice. See, just as I put it, a lot of molecules have come out. There are concepts which were old, are now still going out of the window. The molecules which were once considered to be the sort of amrit, lenoxin, it's nowhere, right? So slowly things are coming, they're changing, concepts are changing, drugs are changing. So our practice is being reinvented on a daily basis, and of course it improves treatment strategies and it redefines disorders, because as the disease understanding improves. See, initially when you had acute I'm sure in the era of Dr. Gagusha, initially when they would treat acute we would just what? You just take rest, give heparin, maybe streptokinase came in later on, streptokinase, that's about it. But today we understand the whole concept of MI. It's a plaque rupture, you have a vulnerable plaque, you have a soft plaque, these are risk factors, vulnerable plaque, vulnerable patient, vulnerable disease, we know everything about it, right? So as the understanding evolves, the therapy evolves, and that is how the innovation keeps on going. Next. A very common slide, yes, this was presented by the Harvard School of Public Health in the World Economic Forum. You can see that if you look at all causes of mortality globally, cardiovascular diseases account for about 31% of all mortalities, and which is second only to other non-communicable diseases as like infections, so on and so forth. Of them, about 61 are about primary prevention, and 32 are patients who have secondary illness. Next. Inter-heart study, again a very interesting study which looked at all the risk factors for the first event. Right? They came out with 9 risk factors. If they are there in any patient, the chances of having first MI is very high. Most important was lipids. That is, you have high LDL, 51% chances of having the first event. Second, smoking. Third, psychosocial risk factors. Then you had physical activity or lack of physical activity, lack of intake of fruits and vegetables, hypertension, diabetes, smoking. So these were 9 risk factors that they looked at. And when he did an analysis, they found out that the risk of myocardial infarction, the first MI, increased about 26 times when all 9 risk factors were added. That is, if a patient has all the 9 risk factors, and he had risk 26 times as compared to a person who doesn't have any of them. So it's a cumulative additive effect, right? So slowly people start understanding that yes, these risk factors need to be controlled, because if you can control them, then probably the incidence of even the first event can go down. Next slide. So Inter study told us that MI risk increases by 26 times when all 9 risk factors are added, and age is a non-modified risk factor. More than 55 years develop the risk. Certain risk factors are modifiable, certain not. Your gender, your age, your race, your ethnicity, you cannot change. We all know that Indians, whether they are in India, Southeast Asia, Japan, UK, US, Canada, various studies have shown wherever Indians are, the incidence of heart disease is much higher as compared to the native population. So there is an ethnic genetic predisposition towards heart diseases, or maybe even diabetes. Diabetes capital of the world, right? 2020 we are supposed to become the CAD capital of the world. There's something wrong, something genetically we are primed to develop these problems. And therefore, when Salim Yusuf came out with a paper a couple of years back, wherein he put in very stringent criteria that if your LDL is 70 or above, Indian patients are at a higher risk as compared to a normal population. For US, UK, Canada, 100 is fine. But in Indians, it has to be 70 or less than that. Because HDL, typical, low HDL, high TG, high LDL subset is what we see in Indians. LDL may be normal, but HDL is very low. Right? Normal lipid profile we look at, in general, HDL would be around 29, 27, 30, 32, not more than that. It is rare to see an HDL which is more than 40 in most of the Indians, even healthy ones, right? So this was the whole problem, and therefore the concept that probably by doing an intervention, primary intervention in the form of medicines, probably you can try and arrest the development of the first event. Percentage, and then there was the concern that most of the people, they're very reluctant to take medicines. Most of our patients, especially because it's a chronic problem, we do interventions, so the patients would believe that angioplasty theke, bypass theke, and then it's not the end of the story, it's the beginning of a story. It is as simple as like calling a plumber and getting your sink cleaned up. एक बार कचरो आयो, कचरो साफ करो એટલે ફરી કચરો ના આવે જવાબદારી તમારી રહેશે. કચરો ના આવે એના માટે શું કરવું? These are things that we need to do. One is disease modification, disease control. That is either by medicines or lifestyle modification. The habits of smoking, tobacco, whatever they are there, they need to be cut down. Daily physical activity, that is very important. What we lack as Indians is physical activity. We are probably a very lazy population. If you go out in a morning walk and if you see somebody walking, he's either a patient or undergone stenting or bypass surgery, or maybe he's an MNC executive. General population, they tend to shy away from, I don't know why, exercises. It's a very Indian thing. If you go out in West, when we go for conferences, when you go out, you get up, you see in a hotel room, most of the people will be jogging. There is a concept that if you are obese, if you are overweight, then you are supposed to be lazy, and even the companies don't hire you because they feel if you are lazy for your own health, you are not good for the company. But in India, the concept is खाते पीते घर का लगना चाहिए. Am I correct? Our kids, if they're lean and thin, तो काकी ने कैसे तो मम्मी खवड़ा दी थी. That's a problem. See, it's not a joke. I'm telling you, why are we having young CADs? Why are we having young CADs? There has to be something, right? It is a cultural problem. It's a cultural problem. We tend to gorge more on sweets. We tend to gorge more on ghee. हमारा पेशेंट है वो घी ना खाता तो ये तो कहीं ना कहीं वाइफ माने कि सर नबड़ाई हमसे तो अरे फ्रेंड कम ऑन घी इज समथिंग दैट वी हैव इन्वेंटेड इट इज नॉट नेचुरल तो आई नीड टू टेल देम कि ओलंपिक में जरा रशियन ने अमेरिकन जो रेस्लर्स होता है वो घी मत ही खाता तो ये लोग जीती जाए तो स्वर्ण पदक तो वो आपने क्या मानते हो कल्चरल there's some myths and beliefs that everybody has कि तेल नहीं खाया तो घुटनों में आने तो थी जैसे है घी नहीं खाया तो नबड़ाई आई जैसे है These are the things that are causing problems. Gujarati is very fond of food. અહીંયા તો ખબર નહીં બાકી સૌરાષ્ટ્રમાં અમે લોકો જઈએ સીએની કરવા માટે સવારે આમ ફાફડા જલેબી જોઈએ ગાંઠિયા જોઈએ તમે જોઈને થાય કે how can you eat this? You cannot. It's not trans fat. But that is how it is. They don't care. But the point is, the reason for having an epidemic of CAD lies with us. It is not as if Upati Gaya Nati used to happen. It is our own cultural, our own thoughts, our own beliefs, our own myths that are causing this problem. And if we don't stop at this point of time, it's going to increase. We as primary care physicians, primary contacts, we need to sensitize our patients and their relatives towards healthy lifestyle. It's very important. કારણ કે તમારે પછી મારી પાસે આવશે અને મારા પછી ઉપર જ જશે. There is nothing else. And mind you, this is very common. પહેલા અમે લોકો 40s માં પેશન્ટ આવતા તો અમે વિચારો ઓ યંગ પછી 30s માં આવવા માંડ્યા તો ખરેખર યંગ છે. My youngest patient I treated is 22-year-old, non-smoker, non-alcoholic, non-obese, B.Pharm student, Karamsad Medical College on campus was doing B.Pharm, had a chest pain at night, went to the ER 1 and 3 Saturday evening, he didn't do anything, and I ran to 5 o'clock, he just couldn't sleep, increased in pain, went back to casualty, ECG probably evolving antibody, massive antibody. Already 5 years had passed by the time he came to me and treated angioplasty, but his LV is still 30-35. just 22. No risk factors. His father is 54, stays in Surat. He was crying in front of me. There has to be something. We need to understand that something is going wrong somewhere, and that is what is happening. Why don't we see this thing in the West? The US might is mandatory to tell everybody to trans fat content of food. Restaurant में जो trans fat content mention ना करे होए, तो they can be fined. It is supposed to be 0, but if it is there, they're supposed to mention it. आपण क्या तो अपने fat content ही नहीं कहता. Forget it, trans fat. Awareness. We don't have any awareness about it. So that is something that we need to really work on. Right. Second thing is that we tend to share from medications. मतलब लोगों ने दवा को एक महीना बाद हमारे पास आया पहले क्वेश्चन सर दवा अच्छी करो. They assume that I am giving this medicines for fun. कि आप खाने का जरूरत नहीं है दवा आपको बताना पड़ती है आपको whatever. So what can I do? So I go for combinations. कि चलो एस्पिरिन लोग अलग-अलग है कंबाइन कर देंगे. स्टैटिन इनिशियल में 80 आ गई चलो 40 कर दे 20 कर दे whatever. We have no combinations wherein you can have a statin aspirin blocker also, so we'll put one combination. You can do with drug. Because तुम्हारा beta blocker, ACE inhibitor, statin, aspirin, beta blocker आप कुछ पड़ा है. No way out. And if it's a diabetic, the diabetes is दवा किसी की मांगा. Right? So certain things, certain ideas, certain concepts, certain myths, certain beliefs, you have to live with. You can't do anything about it. But at your level, there has to be some way out that you can tell the patients that this is correct and this is wrong. Like what they should do, they can do. This is not only true over India, but when they did a study, what called the pure study, they found out that the actual use of drugs was very low. If you look at antiplatelets, beta blockers, ACE inhibitors, ARBs, statins, as you can see, urban rural populations, the graph keeps on going down, and this is the sad state of affairs. Even in cities, at best you can see it was about 60 to 70%, not 100% compliance is very less. Very commonly ब्लड प्रेशर दवा चालू करे पेशेंट 3 महीना પછી સડનલી આવે કે સાહેબ દવા ચાલુ કરી બહુ સારું હતું નોર્મલ થઈ ગયું હતું હવે ફરી વધી ગયું છે ફરી કેટલે વધી જાય એટલે સારું દવા બંધ કરી દીધી they assume they have no idea as to what they need to treat with. In US, UK, Europe, the incidence of serious going down. Why? Primary prevention, and there is a lot of media activity towards patient education. Patients are being taught that this is what is wrong, this is what is correct, this is what you should do, and this is how things are. After that, there is no effort by anybody to educate patients. And I think it is mandatory on our part to educate them regarding that this is very important. Whether it is hypertension or diabetes or heart problem, whatever it is, they should know कि यह प्रॉब्लम है आप एक करवानी जरूर है. मतलब पेशेंट वुड नॉट नो कि मारा શું કરવું છે કે દવા पे दवा ले ली तो आपको दिख फिर दवा ओके है. Tell them they nothing. These are things that you are supposed to do. If you do this and take medicines, you will be okay. If you don't, their chances will come back. So that idea has to be there in the minds, and it should be very clear. The onus has to be on the patient. आपने શું કરી છે દવા લખીને મેં દોરો सन આવશે એટલે કાલે ફરીથી કહે કે સાહેબ તમારો દવા તોય નથી. That there is a reason for that. Tell them that the onus lies with you, not with me. I can only help you out. That's it. This is what you are supposed to do. This is what things that you need to do. If you do all this, you will be healthy and fine. Otherwise, you are going to come back. I tell very bluntly to my patients, there are few patients who cannot stop smoking. Sir, I should not say this, but there is a patient who he's a rabari, and in this sudden, I know what was going on. He was one of those people who was the middleman who get all the land sold to the brokers and all. So sort of a dada gunda sort of a person. So he said, sir, હું જો બીડી પીવાનું છોડી દઈશ તો પછી લોકો માથી પીશે નહીં એટલે મારો ધંધો ચોપટ થઈ જશે એટલે મારે બીડી પીવી જ પડે. How do you answer this? So I said, fine, એક કામ કરો એક FD મુકાવી દો દર વર્ષે 2 લાખ તમને આપી દેવાના હું તમારી મેડિસિન કરી દઈશ. So then he understood કે ના ના સાહેબ એવું તો કરી દેશે એવું જ હોય. If you keep on smoking, it is going to recur every time it is going to process બનાવવા લાગે. Then he thought કે ના this is not it. કારણ કે 2 લાખ તો બતાવે પર લેવલ ટેન્શન થાય દવા તો એટલે જ. So in their own ways, in their own language, tell them this is what it should be and this is how it should be done. Only then can you actually achieve what you really want to achieve. Next. So the key to solution, we all know that there is risk reduction associated with interventions, that if you reduce blood pressure, the reduction will be around 20-25%. Stroke, of course, it is more. Dyslipidemia, again, stroke reduction is there, NCD reduction. Platelet availability. Again, the risk reduction is much more for CGS compared to stroke, but yes, definitely. If you look at all of them, then probably you get a much robust overall reduction in risk. And therefore, we know that treating a risk factor alone is not effective. Just treat blood pressure doesn't help. Just treat LDL doesn't help. Just treat platelets test doesn't help. So you need to have a concise and compact treatment for all of these. Next. Next. And we also know that better risk reduction is possible. That we have data to show that it just causes 10% reduction in blood pressure. Added with 10% reduction in total cholesterol, you have 45% reduction in cardiovascular diseases. Enough data, enough trials. We know very clearly. Just historically, if I 10 हो चुका हो, मैं सारे LDL के सामने 30 हो चुका हो, तो the reduction distribution rate 40 to 50%, which is huge. If you look at it in number wise. Next. Cumulative reductions, aspirin, beta blockers, statins, ACE inhibitors, combined effect nearly 75%. So when they looked at all the data, they found that nearly 75% of CV risk reduction is possible if you combine all these drugs, give it to the high-risk population, and probably that's going to work. It's going to help. Next. This is what Dr. Nicholas Watt said in his paper, that combined effect would be around 88% for ISD events and 80% for stroke events. Again, huge numbers. Next. Compliance is again another issue. As I said, compliance with therapy, first few months they'll be very good, they'll be very happy. Shmashan Vairagya, post-bypass, post-angioplasty is always there. 6 months they'll not smoke, no drinking, exercise, drugs, everything. 6 months later, slowly they'll start shedding everything. Well, exercise बंद था, कभी बीड़ी चालू था, दवा ओછી था, साबु છે, એક દિવસ લીધી નથી લીધી, કોઈ થતું નથી. એટલે અઠવાડિયું નથી લીધી, કોઈ થતું નથી, એટલે મહિનો નથી લીધી. સડનલી કમર નમાઈ. So that's the problem. We have a lot of data that has shown that patients tend to discontinue or they reduce the amount of drugs that they take, alternate day therapy. And patients say, sir, एक दिन छोड़ने लो छो. केम? बस साहब लो छो तो मैं तकलीफ था ऐसे, आम था ऐसे, तेम था ऐसे. All non-specific symptoms they will like to attribute to your medicines. Weight gain, medicines. Cough cold, medicines. Weight loss, medicines. Whatever you do is medicine that is causing a problem. So that is a culprit, so stop it. The first reaction that they will have, and that is what you need to really fight against, because if they don't understand the importance of what you are giving, not only their mindset will always be doctor का care and doctor को आपे आपे करवाना नहीं, and that is a very deeply ingrained psyche of our patients. The doctor को care, but you have to tell them कि care कैसे है. If you tell them that, if you convince them, if you educate them, most of them will try to adhere to what you are trying to do. Next. Again, it is also known that non-compliance, as it goes down, survival also goes down, and that is just in a matter of few months. In a matter of a year, you can increase mortality when the patients stop taking the medication. That 100% survival, it comes way down to 10% reduction in survival. Next. So then came the idea of maybe combining everything, because to give 4 drugs, patient may take, may not take. One day is taking, another is not taking. So why not to put them everything in one, make it one deal. Give it to the patient, we will eat it, we will be fine. The only way to improve compliance is to ensure that the patient is taking all the medicine. How else can you ensure? Nothing. So if you roll everything into one, give it as one capsule, patient takes it, is happy. एक गोली दररोज सवारे लेवानी है, he's happy with it. With 4 गोली તમારે લેવાની એટલે then starts the problem. સર મને કશું છે નહીં, 4 गोली કેમ આપો છો, આ કેમ લેવાના, આ કેમ લેવાના? But if you pack it in one, give it to him, that is the thing. So adherence, leading risk reduction, that was the concept that was worked on. Next. So the milestones were probably 2003-4 when the concept of Polycap came out. They started working on that. TIPS 1 was completed in about 2008-2009. It was published in the Lancet. Then came 2002, TIPS 2, where they looked at the secondary prevention. TIPS 1 was a primary prevention, and the various awards. 2013, TIPS 3 is still going on, and they're looking at a long-term data now, 5-year data. Once we are given this combination, how does it work out? Next. As I said, it has 3 antibiotic drugs. Atiprol has atenolol 15 mg, ranitidine 5 mg, simvastatin 20 mg, and aspirin 100 mg. Next. So what does it give? Well, it gives us freedom. I will not say freedom, but yes, reduction in diseases, in incidences from heart disease, stroke, peripheral disease, and diabetes mellitus, especially those of 55 years old, regardless of risk factors. Probably the concept is that if we take this polypill, the incidence of event rates will go down. That's a hypothesis, that's a concept that we are working on. Probably if that is true, and maybe a lot of patients can benefit. In US there was a movement wherein they said everybody over 40 should take aspirin, they should take statin. There was initially a movement wherein they said 145 the water that you take with statin and aspirin. Why not? પાણી માં નાખી દેવાનું 145 વિટામિન ડી 45 ગ્રેડ આવે છે એટલે સ્ટાર્ટિંગ આસ્પિન 45 પાણી આપવાનું બધાને. It's epidemiology primary prevention. So people were working on that, and but some of things didn't work out. So probably this is something that, if proven, probably could give us the answer to our problems. Next. Then comes the question that if you pack everything, what about the medicine? Whether these drugs will interact with each other? What about the availability? We have 4 drugs inside, 4 powders. So what if they don't work out to be the same? Because given individually they will work fine. But what if we have aspirin, beta, everything in one, this thing. So, but there is a paper that came out which showed very clearly, Carlos 2010, that all the drugs usually maintain the bioavailability, no pharmacological interactions. The compliance was pretty good, and it preserved the mutual pharmacological profile. You can see that the effect was almost the same. Aspirin, ramipril, simvastatin, atenolol, and hydrochloride. Because the parameters are not drastically different, therefore you know that even if you combine them, the effect is going to be the same. And if the effect is going to be the same, the risk reduction is going to be the same. Right? Next. So what did it give? Tips. So it told us that it gave us a better control of blood pressure. If you just give one blood pressure lowering medicine, the reduction was about 2.2. 2 medicines, 4.7, 3 medicines, about 6.9. But if you get a Polycap, probably the reduction was about 7.4 systolic and about 5.3 systolic, which is a big number. And not very drastic, but still it is enough to cut down the excess risk. Reduction in heart rate, reduction in LDL levels, improves blood aggregation, and effects are similar to individual drug regime. 85% of patients complete trial in the Polycap arm, which shows that their compliance rate was good. And therefore they concluded Polycap reduces multiple risk factors that improve compliance. This was Lancet 2009. Next. Again, similar data showing that whether it was simvastatin alone or the Polycap arm alone, the reduction in LDL was same. Similar reduction in 11-dehydrothromboxane B2, which is a marker for thrombosis. It shows the platelet aggregability. So it is a reduction, that there is improvement in that, and therefore it was similar. And the reduction in both LDL and platelet activity was almost same. Next. Then came tips 2. What they did was that tips 1 they showed that it is safe. Tips 2 they went one step further. I combination से डर के आपरे कोई ने double dose आती है. So whether it is going to cause any harm or benefit, they want to study that. So they did 2 arms. One was basically having the same Polycap formula. Second was 2 capsules of Polycap, and they added potassium because hydrochlorothiazide was there. So they thought maybe it could cause potassium loss. And on target sub-study, if you look at, you will find that patients who had increased urine potassium actually had better outcomes as far as stroke was concerned. So they added potassium to mitigate these things, and they found that full dose, as in 2 capsules, showed superior reduction in blood pressure and LDL as compared to half dose. And the tolerability was similar in both the arms. So they said that probably if the patient requires, you can go to 2 dose, 2 capsules, no issue. Next. And there's an app therapeutic option for high-risk CV patients, secondary prevention, easy dosing and easy to titrate, not a problem. You start with 1 capsule, patient tolerance, go to 2 capsules, should be better because the reduction in stroke, MI is much better as compared to just 1 capsule per day. Next. Then came the Empire trial. This was again on the concept of Polycap, not to do anything with Polycap, but it showed basically that the compliance increased 3-fold if you gave them a combination of medicines in a single formulation. Patients tend to stick to the regimes much more as compared to if you give them separate drugs, separate tablets in different forms. So this is the DC Polycap 77% as compared to usual regimen of 23%. Next. And based on all this, Label Society Guidelines 2012, they clearly said that individuals without CVD demonstrated that Polycap formula could conveniently reduce multiple risk factors, especially in patients who are more than 55 years old. So this was endorsed by the Label Society on the basis of the data that is available, tips 1, tips 2, Empire, Your. They told very clearly that if you do this multiple interventions, probably things will be better as far as primary prevention goes. Next. And there have been a lot of recommendations from organizations like European Society, American Heart, the National Institute for Heart and Clinical Excellence, ACC, where they said that reducing dosage demands is the most effective single approach to enhancing adherence, fixed dose combinations, it reduces dosage demands, and increases patient compliance, and therefore improves patient next. So to summarize, Polycap program is a unique example of innovation which is affordable, because if you look at the cost of individual tablets and if you look at the cost of Polycap, it is nearly 1/3. It has shown efficacy and safety in randomized trial patients, so we know it works and it is helpful. The effective strategy to prevent millions of deaths from CVD, high-risk primary and secondary attacks, and clinically studies have shown that polycap surgery could improve compliance in patients, and they have been endorsed by other organizations. Next. So just to sign off, I will say that the way to live a long life is to get a chronic disease and take care of it. If you can do that, probably you can fight all the adversities and go to, as you can see, it's climbing a mountain towards better health. And that is how I think things are. So, few things. First, polycap concept is genuine, it is true, and if it holds, probably we'll see a drastic reduction in primary as well as secondary events. First MI and subsequent MIs could go down, strokes could go down. You could have a blanket reduction of, or say blanket control of dyslipidemia, hypertension. You could improve the cardiac ability in these patients, and therefore give them reasonable protection for any future event. That is done. That is we know by various trials this is how it should be. There have been efforts to study this, and I think two studies done by Cadila have definitely shown us that yes, it is a concept, it is safe. You can give them even double the dose that they have tried of standard Polycap. Still, there is no issue as far as tolerability safety is concerned. So yes, you can try them, and that it should be done so that it is high-risk patients. I will not say maybe give it to everybody who is above 55, but yes, high risk. If you are diabetic, hypertensive, smoker, dyslipidemia, history of heart disease, premature atherosclerosis, stroke, PVD, renal stenosis, those are the patients where you should give this combination so that you can at least try and prevent any future. That is second. Third, there are a lot of questions that come to our mind. Yes, there are 4 molecules, some of them are old, there are so many new molecules available. What about the patient who requires an added dose? What about patients post-MI, where the patient with clopidogrel would maybe require a high dose of beta blockers? What about them? Just can't give one capsule. No, you can just add on. You can just add on clopidogrel again. Maybe you can add on an extra dose of statin. If your sensitivity is less, you can add 20 more, 40 milligram, 18 milligram is fair enough. So these are certain things that you can do so that your patients are not left out. When you are looking at therapeutic, see, this is prophylaxis. This concept is prophylaxis. This is not therapy. This is prophylaxis. When you talk of therapy, it is tailored. It is going to be targeted. So when you look at a targeted, tailored therapy, maybe as an add-on, you can add whatever you wish with this particular, because none of these molecules are known to interact, with other molecules in a bad way. It's not like cimetidine or not like antifungals where you can give certain drugs. So I think that way it is a very safe formulation, and if it really works, maybe 25 years down the line, you will be
Normally, when the person is treated as a hypertensive, single drug therapy is started. In this case, you have over 3 drugs and they are very expensive. So, what were the content of each one?
Yes, because hydrochlorothiazide was 12.5 milligrams, 12.5 hydrochlorothiazide, and your atenolol was 50 milligrams, and ramipril was 5 milligrams. See, the concept was evolved, as I said, way back in 2002-2003, but the concerns that you have, everybody has those concerns. To give 3 anti-hypertensives to a patient, how safe it would be. And that is what probably they answered by doing the tips 1 and tips 2. As I said, the reduction is there, but it is not so huge that you expect hypotensive episodes or patients dropping down, or nothing of those things actually happen. So it is pretty safe to give at this particular. This is a dose. If you look at the clinical trials, it's nearly half the dose that you tend to give therapeutically. For pure hypertension, if you want to give ramipril, probably the dose would be around 5 to 10 milligrams. Hydrochlorothiazide 12.5, maybe twice a day. Atenolol 50, not necessarily working every time, it will be nearly 100. So this is nearly half of the dose that you tend to give for a a pure hypertensive patient. So probably that is why it's not too bad. But see, now that you have atorvastatin or rosuvastatin, all the statins have gone out of favor. But when this concept was being formulated at that time, you had pravastatin, you had simvastatin, atorvastatin had just come in, you had lovastatin still going around, and there was a very clear concept that pravastatin was for primary prevention, simvastatin was for secondary prevention. A very clear concept. Atorvastatin was still coming up. Forest trial, there's so many trials that very clearly show that simvastatin is actually a good drug to give. Even today, in diabetics, they do say that simvastatin is a much better drug to give as compared to atorvastatin. So then they thought, see, they had to make a choice. That what statin to give. So then they studied the data and they found that probably simvastatin is safer and more effective. And so the choice came to rest on simvastatin. So that is how things are. And probably 20 mg of simvastatin, if you look at primary prevention as a prophylaxis, it is pretty safe and pretty effective. So I think that's how the choice came. Yes, that's a matter of debate. It's as I said, innovation. 2003, 2004, Simba was the drug of choice. Today, it is nowhere to be seen. There is one company who is promoting simvastatin in India, and two companies or more. Now, things are moved on to atorvastatin, rosuvastatin. So, probably that is what time will do. That was a system done. That maybe you can try a combination of various molecules. So, time to time is going to change. 5 years later, rosuva might go out of favor. You have something new on the horizon. So, then you need to check that out. But this is a concept I'm looking at. But maybe you have a combination of statin with aspirin, with beta blockers, with ACE inhibitors, with thiazides or diuretics would work well. It's a concept. Now you can substitute whatever you wish, and probably you may get the same results. We don't know, but probably I assume that you may get same or maybe better results.
The other question when we have combined first here we do get drastic.
Exactly. That is why the safety study was carried out first. The efficacy they are doing right now. It's an efficacy study. They are studying whether this combination really works and if it works, how well it should be. See, Wald and Law told us that it is 86% reduction, right, if I am not wrong. But Tips one told us the reduction is not 86, but it is 67, 68. It is there, but not drastic, but it is still there. Tips will tell us actually how much it is there. Over a period of 5 years, we look at the reduction and even then will come to exactly how much it is. So the first, initially the concern of safety have been addressed. That is, it is a good combination, safe combination can be given. We know the reduction that are being caused across LDL, across the systolic and diastolic blood pressure, so on and so forth. So we have established the safety. The efficacy is something that we should be looking at now. And that is what probably they are planning to do with the 15th trial.
The incidence of RTP very less with Civil Hospital compared to a drug hospital. If it is 0.03 and 0.7 with a drug hospital.
See, the point with statins is that there is a lot of dose relationship with the molecule. What is 40 mg of simvastatin would be about 10 mg of atorvastatin. And therefore, the incidence of side effects in diabetes will definitely be less with 10 mg of atorvastatin as compared to 18 mg of simvastatin. So, simvastatin 20 mg is like giving every 5 mg of atorvastatin, or maybe 7.5 to 10 mg of atorvastatin. So, that way the overall incidence of side effects or the fear of side effects would be far less. To be very honest, to have seen actual myositis or myopathy requiring stoppage of statin is not so high. The perception of fear is very high. You always feel कि 18 mg खरीद देता है, इसलिए ना पाए, आम तेजी से 3 mg का होता है. We are routinely giving 40 mg of rosuvastatin, 80 mg of atorvastatin without any problems. I mean, we don't give for years, but yes, for first couple of months we do give post-intervention because we need to pacify the plaque, we need to modify the whole lipid profile, we need to modify the plaque itself. So we do give high doses and nothing really happens. So that fear is there, not only for statins, even for beta blockers. We don't tend to go beyond 50. We will add ivabradine, we will add diltiazem, but we will not go to 100. Why not? The fear is there. The fear complex is much there. Aspirin, we don't tend to give 300 mg because of fear that they might be GIP. GIP thirst effective. At the effect comes, then the side effects come. You can't have side effects before effects. When the effects come, when the side effects will come, you can always stop it, modify it. They are all dose related. There is nothing irreversible. You stop statins, they go away. Stop aspirin, GIPs go away. So rather than to be fearful of a medicine, I think it's better to give it at a proper dose. That is more important.